This meeting is being recorded.
Welcome, everybody. We are going to give attendees about 2 more minutes to join, and then we'll get started. All right, we are going to go ahead and begin. Welcome, everybody, to this webinar on the Couple Years of Protection Indicator. Thank you so much for joining us this morning, afternoon, or evening. We're really excited to see representatives from so many implementing partners and host countries in attendance today. My name is Audrey Freitas. I'm a technical officer in the Product Development and Introduction Department at FHI 360. And I'm joined today by both my FHI colleagues and collaborators from the U.S. Agency for International Development and Avenir Health, who will introduce themselves as they present. We do have a few housekeeping items to quickly go over. Next slide, please. First, this webinar is being simultaneously translated into French. To access the French audio, you can select the interpretation option in the meeting tools at the bottom of your Zoom window, and then select French as your preferred language. That option is marked by the globe icon you see here. Next slide, please. We welcome your questions at any point in the meeting. Please use the Q&A option rather than the chat option to submit your questions. Our presenters will respond either in writing during the main portion of the webinar or verbally during Q&A at the end of presentations. The webinar is being recorded. You will receive a link to both the recording and to the slides presented today. Next slide, please. We will begin with recorded remarks from Ellen Starbird, Director of the USAID Office of Population and Reproductive Health. Thank you again for joining us, and Megan, go ahead and begin the video whenever you're ready.
Good morning, good afternoon, and good evening. I'm Ellen Starbird, the Director of the Office of Population and Reproductive Health. Welcome everyone to this webinar on the revised conversion factors for the Couple Year Protection Indicator, or CYP. The objectives of this webinar are to update key stakeholders about the new CYP conversion factors, reinforce guidance on the appropriate data sources and use of the CYP indicator, and to discuss and encourage country dissemination. CYP is an output indicator that was introduced into programming in 1973 and is used by USAID and other international organizations and host country governments to monitor progress and measure performance of family planning programs and to inform decisions about family planning coverage. CYP is the estimated protection provided by family planning methods during a 1-year period and is calculated by multiplying the number of units distributed, whether for sale or for free, by a conversion factor that quantifies the duration of contraceptive protection provided per unit distributed and per procedure. CYPs for each method are then summed over all methods to obtain a total CYP figure. CYP includes permanent methods such as sterilization, as well as the lactational amenorrhea method. The most updated CYP conversion factors are available on the USAID website, and the link to them is provided at the bottom of this slide. As I noted, CYP measures the estimated protection provided by family planning based on the volume of contraceptive methods distributed to clients to help monitor health system performance and track trends and progress over time. It is a required indicator for USAID family planning programming, and our office and missions use it to track progress in the delivery of contraceptive services to clients. The measure is currently one of the most widely used output indicators in international family planning programs, and it has several advantages. It can be calculated from data routinely collected through programs or projects, and thus minimizes the data collection burden. These data can be obtained from all the different service delivery mechanisms: clinics, community-based distributors, social and commercial marketing. It's a relatively simple calculation to do, and it allows programs to compare the contraceptive coverage provided by different family planning methods. The rest of this webinar will cover how CYP conversion factors are calculated and why specific method conversion factors and not others were revised. I want to thank the USAID colleagues that formed a CYP working group in September 2020 and partners Avenir and FHI 360 for supporting the current CYP revision. It was a big piece of work. Because there are substantial recent changes for specific method conversion factors that could impact project and country CYPs, it's important that this information be disseminated to your family planning network and to country partners who use the CYP to monitor progress. Thank you for being with us today. I'll now hand it over to my USAID, FHI 360, and Avenir colleagues to provide more details on the revised conversion factors.
Hello, everybody. I'm Tabitha Sripipatana. I'm the Deputy Division Chief for the Research Division in the Office of Population and Reproductive Health at USAID. My presentation is providing a bit of background on what is included in developing the CYP conversion factors. Where do those numbers actually come from? And I want to note for any USAID mission colleagues who may be joining today that this is the same presentation that was done internally on April 21st. Next slide. So the CYP conversion factors are not revised frequently. The last 2 updates were in 2000 and 2011. During this latest review in 2021, an informational brief was created that provides details on the revision process, including what new data will launch a revision cycle. The CYP for each contraceptive method is calculated by multiplying the number of units distributed to clients over 12 months by a conversion factor that quantifies the duration of contraceptive protection per each unit distributed. Next slide. How is that conversion factor created? The methodology has evolved over the decades, and some data have proven more useful than others in calculating coverage. The method characteristics and data included for calculating the conversion factors are different for the different methods. For example, duration of protection is very different between pericoital or single-use products versus long-acting methods. We have to rely on the best available data sources and sometimes on expert opinion when high-quality data are lacking. The key characteristics included in developing conversion factors are use effectiveness, which is applicable for all methods, the average duration of use, which applies for the long-acting and permanent methods and fertility awareness methods. We update duration of use when there is a label change for a product, when there is a medication presentation change, and when there are new continuation data. Mean coital frequency is considered for coitus-dependent methods such as condoms, spermicides, and emergency contraception. And data on consistency of use is applied for condoms and spermicides. An estimate of wastage when products can be discarded prior to use is applied for pills, condoms, and spermicide conversion factors. And then characteristics considered in conversion factors have been revised over time. For example, the overlapping coverage or using more than one method simultaneously was removed from consideration in 2011 as the available data didn't make a significant difference in the final conversion factor. Next slide. Now that you have some background on what characteristics are considered in conversion factors, Elena Lebetkin from FHI 360 will go through the decision-making for the revisions made in 2021. I just want to reiterate Ellen's message about disseminating the revised conversion factors, especially in country, specifically to Ministry of Health counterparts. This may require a calculation change going forward. We're not changing things retroactively going forward for some of the products offered in country programs now, and it also highlights products that may be introduced in the future. The webinar recording and slides will be made available to attendees. These materials can be broadly disseminated to partners. And please access and feel free to share the couple years of protection brief, which is available at both the USAID and FHI 360 websites. So thank you very much. I'll come back on video to say thank you, and I'll hand this over to Elena.
Thank you, Tab. Hi, everyone. Good morning, good afternoon, good evening. My name is Elena Lebetkin, and I'm a Senior Research Associate at FHI 360, and I sit in the Product Development and Introduction Department. So, as we've discussed, today I'm going to be sharing about the updates to the couple years protection, or CYP factors. And as Tabitha mentioned, the last update was conducted in 2011. So this presentation is going to focus on evidence and updates post 2011. And I'm presenting this work on behalf of a team from FHI 360, Avenir Health, and USAID that conceptualized and implemented this work. And of course, we would like to thank USAID for funding this under the FHI 360 Innovate FP Cooperative Agreement. Next slide, please. So first, I'm going to walk through the process we developed to determine when and whether to update methods CYPs. So our goal here was really to create and document a transparent process that could be replicated for future CYP updates. Now, based on this process, we determined that 5 methods needed updating. I will then share the evidence and new CYPs for these 5 methods. Next slide, please. So in order to determine if a CYP change or a new CYP is needed, you'll first need to assess if any of the following apply. So first, is the method new or newly available in low and middle income countries? Second, has the labeled duration of use been changed by a regulatory body? Or third, has the method presentation changed? For example, this would include a change in the quantity of the product in the package. Next slide, please. So once you determine that a method fits into one of these three categories and needs a CYP or updated CYP, you can follow this flow chart to decide how to update the CYP. So if you start from the far left, if a method is new or newly available in lower middle income countries, the method doesn't have a CYP yet and will need one. For methods that fall into this category, you can use past approaches of calculating CYPs of related products to inform the new method CYP. So for methods that fall into the second category that have had a duration of use change, you can use past approaches for calculating CYP to inform updating the CYP for the method. And for the third category that have had a presentation change, first you need to determine if the change is significant enough to warrant a new CYP. So for example, if the branding changed, you would not need a new CYP. But if the number of pills in the package changed, you would need a new CYP. So to determine this new CYP, you should use past approaches of calculating the CYP of the method in question or related products to inform the update. So next, I'm going to walk you through the approach, applying these approaches in this flowchart to the 5 methods that need updating. Next slide, please. In this slide, I'm going to introduce the 5 methods that need updating. So in the new and newly available category, we have 2 methods, the Kaya diaphragm and the levonorgestrel 1.5 milligrams for paracoidal use. So I will refer to this method as paracoidal contraception throughout the presentation. So as many of you are likely familiar with, there are 2 kinds of diaphragms. There are fitted diaphragms, which has been around for decades, and the newer Kaya diaphragm, which is single size and does not require a fitting. So fitted diaphragms were removed from the CYP list in the 2011 update, as use was very low in USAID funded programs. But with the introduction of the new Kaya diaphragm, plus considering any use of fitted diaphragms, we determined that the diaphragm did indeed need a CYP in this round of updates. The next method that falls into this category is paracoidal contraception. So when levonorgestrel 1.5 milligrams emergency contraception is used paracoidally, so around the time of sexual intercourse rather than strictly after sexual intercourse, it's referred to as paracoidal contraception. So this is an off-label use of emergency contraception that has been studied in recent years, and anecdotally, we have heard about increased use as a form of regular contraception. So we felt that paracoidal contraception did need a CYP factor, and hopefully it will help promote normative guidance, such as the addition of this method to the WHO selected practice recommendation, and potentially support WHO pre-qualification for this method. Now moving to the second category of methods that had a duration of use change by a regulatory body, we have 2 methods that fall into this category. So first we have Levoplant, formerly called Sino-Implant 2, excuse me, and the hormonal IUD. So Levoplant was changed from a 4-year to a 3-year method, and the hormonal IUD was changed from a 5-year to a 7-year method. And finally, the third category where methods had a major presentation change includes one method, the progestin-only pills that are being procured now by USAID in a 35 pill pack rather than a 28 pill pack. Next slide, please. Now I'm going to run through the 5 methods that need update by sharing the literature available since the 2011 CYP update and by sharing the updated CYP. So first, I'm going to talk about the diaphragm. So as I mentioned earlier, there are really 2 types of diaphragm. There's the fitted, which comes in multiple sizes and requires a provider to do the fitting to determine the correct size. And there's the Kaya diaphragm, which is a single size diaphragm that fits most women. So when the CYP factors were reevaluated in 2000 by Stover and colleagues, the only diaphragm available was the fitted diaphragm. So they ended up assigning the diaphragm 1 CYP, stating that it was an educated guess and there were no empirical data available. So, excuse me, as I noted earlier, the diaphragm was dropped from the CYP table in the 2011 update as use was low. So in reviewing the literature since 2000, we found 2 published studies, one of which estimated a 57% 12-month continuation rate of the fitted diaphragm, and the other, published just this year, actually just in the last month or so, estimated an 84% 6-month continuation rate of the Kaya diaphragm. Next slide, please. So since Kaya is a new method, we use past approaches of calculating the CYP of related products to determine the most appropriate CYP for Kaya. So as the data were very limited and they were fairly consistent with the previous estimate, which was based itself on limited evidence, we decided that it made the most sense to revert to the original 1 CYP per diaphragm and to apply that both to Kaya and fitted diaphragms. Next slide, please. So now I'm going to discuss paracoidal contraception. So as mentioned earlier, paracoidal contraception is the off-label use of emergency contraception around the time of sexual intercourse. We found one published study by Feston et al. That estimated average monthly use of 4.85 doses with a 92.9% effectiveness. So we're also aware of another study conducted by Camber Collective in Ghana with results not yet published, yet they were able to share some key data points with us. And so in that study, the participants averaged 1.72 doses per month with an effectiveness of 97.9%. So we took the weighted average of the average monthly use and effectiveness from the 2 studies and came up with an average monthly use of 2.5 pills and an effectiveness of 96.6%. So I wanted to note that we are aware there's another study being conducted with paracoidal contraception in Kenya, and the results are not yet published. We did learn that the results are very similar to the Ghana study, so we don't feel that this additional data point would greatly change the estimate. Next slide, please. So to calculate the CYP for paracoidal contraception, we adapted the approach used of calculating the CYP of oral contraceptive pills. So here we calculate the number of doses required per year by multiplying the number of pills required a month by 12 months per year. So we then divide the 96.6% effectiveness to get 31 pills or doses per CYP. However, since data are sparse and the CYP is really a crude estimate, we decided it made the most sense to simplify the estimate to 30 pills per CYP. Next slide, please. So now I'm moving to the second category, methods that had a labeled duration of use change, and I'm going to start with Lebetkin. So this product was initially registered as a 4-year product and was assigned a CYP based on this 4-year duration of efficacy. But subsequently, the product was pre-qualified by WHO as a 3-year method based on study results and is now registered globally as a 3-year product. Next slide, please. So since there was already a CYP assigned to other 3-year implants, we used the same calculation for Lebetkin and applied the same CYP calculated for the 3-year implants, Implanon NXT and Implanon. So now Lebetkin, Implanon NXT, and Implanon all have the same CYP at 2.5 per implant. I just want to note that the 5-year implant Jadel continues to have a CYP of 3.8. Next slide, please. So the next method that had a duration of use change was the hormonal IUD. So in 2021, the FDA extended the duration of use for the Mirena IUD from 5 to 7 years. We expect that national drug regulatory authorities in low and middle income countries will likely follow suit in the coming years. So we need to calculate a CYP for the hormonal IUD using the 7-year duration. The CYP calculation for the hormonal IUD in 2011 relied on continuation rates of the copper T380A and resulted in 3.3 CYP per hormonal IUD and 4.6 for the copper IUD. So at that time, there were no continuation rate data from low and middle income countries for the hormonal IUD, and US data were largely limited to clinical trials. So the general consensus at the time was that hormonal IUDs had a similar continuation rate to copper IUDs and implants. However, since the 2011 CYP update, continuation rate data for hormonal IUDs have been published. So if you look at the table here, at the first 2 rows of data from the CHOICE study in the US and the LEAP study in Zambia and Nigeria, you'll notice a higher continuation rate for hormonal IUDs than copper IUDs, except in year 3, where rates are equivalent in the CHOICE study. The Xiao study in China did not compare IUDs, but did estimate a fairly high 1-year continuation rate for the hormonal IUD. And finally, the Roe study is a bit of an outlier with lower continuation rates for the hormonal IUD, though it is important to note that the study was published in 2016, but it was actually initiated in 1993. And at that time, there was little information and counseling done, little information provided and counseling done for contraceptive-induced menstrual changes. So it's been theorized that the low continuation rate for hormonal IUDs seen in this study is because of this lack of counseling. Next slide, please. So as discussed in the previous slide, the prior CYP calculation for the hormonal IUD used a modeled copper IUD continuation curve to calculate the CYP. However, if you look at the more recent data we just presented, the hormonal IUD has a higher continuation rate than the copper IUD, so it really doesn't make sense to continue using the copper IUD curve to estimate the CYP for the hormonal IUD. Continuation rates for the hormonal IUD actually are very similar to implants. So we decided to use the modeled curve for implants to estimate the CYP for the hormonal IUD. So when you look at this modeled curve and you truncate it at 7 years to account for the duration of efficacy, you end up with 4.8 CYP per device inserted. So by truncate, I mean that women in this modeled curve who have not discontinued prior to year 7 will be assumed to have discontinued at this point. And I'd also like to note copper IUDs continue to have the same CYP at 4.6 per insertion. Next slide, please. So finally, progestin-only pills are the last method that had a CYP change, and they fall into this third category of presentation change. USAID, as I mentioned earlier, has switched from procuring the 28 pill packs to the 35 pill packs. So we didn't need to do a literature review for this method since the change was just in the number of pills in the pack. Next slide, please. To calculate the CYP, we used the same approach used previously and adjusted the number of pills per pack. To accommodate for wastage and for simplicity, the CYP for USAID supplied progestin-only pills is 12 cycles or pill packs per CYP. Next slide, please. So this table summarizes all CYP factors with the new factors in bold. And as Tab mentioned, the updated information is available in multiple places, including the USAID CYP website, the D for I, Family Planning Reproductive Health Indicator Database, and on FHI 360's website in the brief that we developed that summarizes this whole process. Next slide, please. So I'd really like to thank everyone involved in this process. It was really a collaborative effort, and it couldn't have been completed without everyone you see here listed today. I would like to thank USAID for funding this. And if you have any questions, please feel free to reach out in the email address provided. And now I'm going to be handing it over to Amani to discuss additional updates. Thank you very much.
Hello, everyone. My name is Amani Selim. I'm the Senior Monitoring and Evaluation Advisor in the Office of Population and Reproductive Health in the Global Health Bureau. I want to thank you all for attending this webinar, and also to thank my PRH and mission colleagues who've provided input and feedback and questions on this indicator over the past 2 years. As you've seen earlier this morning, several updates have been added to the CYP indicator. Just now, we just heard about the changes to the conversion factors and method-specific information. Next slide. So what else was updated? We updated the indicator reference sheet, the definition, source of CYP data, and started a discussion about proxy indicators in the case of different sources. Next, please. So in the definition, we used the term methods instead of services in order to include and focus on all methods. And we added that the indicator also includes permanent methods, such as sterilization and the lactational amenorrhea method. No other changes were made to the definition except for highlighting that CYPs track distribution to clients. Next, please. We also updated the data source. So the ideal source, of course, is data collected from family planning programs that provide family planning methods and services to clients. It's data that measures actual distribution to clients. It doesn't measure the volume of contraceptives that are procured or distributed or stored in facilities or in warehouses. The source of the data could be facility level service statistics, health management information systems that are at the facility level, DHIS2, and or implementing partner reporting. Supply chain data that's related to family planning commodities in warehouses, or that measures just family planning stock in country at different levels, or that is delivered or in storage at district or health facilities, should not be used to calculate this indicator. The calculation of CYP is based on family planning services and products provided to clients. If this information is not available, then a proxy indicator may be introduced and calculated to measure the volume and or the value of the family planning commodities just for reporting purposes. Next slide, please. So when and how do we use proxy indicators? In some projects, such as social marketing projects, it may be difficult or perhaps impossible to monitor the exact numbers of contraceptives reaching the hands of clients. In these cases, for reporting purposes, a proxy indicator may be calculated based on the volume of contraceptives delivered to retailers that are selling the contraceptives to clients. And if a proxy indicator is calculated using data from logistics management information systems, the LMIS, warehouse supply or delivery, stock on hand, or similar sources, those preparing the report should state that this is a proxy and provide details on what source of data was used so that the users of this information would know what does this measure reflect and what is the actual data source for this indicator. Next, please. So all of these changes that I just mentioned will be reflected in the CYP indicator reference sheet for our PPR standard indicator for our mission colleagues. And it will begin with the FY22 reporting. And as Ellen mentioned in her message, please share this new information with your counterparts in ministries of health and with your implementing partners. So these are the sources where you will find the latest changes to the indicator. There's the USAID CYP page. It was the first data for impact in the indicator database. And of course, the FHI 360 site where you will find the studies and the new indicator reference sheet. Next, please. So I really want to thank you again for your collaboration with us in refining this indicator and others that we'll start working on. And for all our mission health colleagues, if you have any questions or concerns about this indicator or others, please contact us through your family planning liaison in your country team, and we'll do our best to respond to them. And special thanks go to the PRH staff who actually contributed to these changes: Wazi Montali, Sean Malarsha, Kali Fisatan, Bakar Maggwa, and Smita Gaith. And our colleagues at Data for Impact, Janine Bardon O'Fallon and Bridget Adamu, who are the keepers of the indicator database. Thank you for your assistance. And of course, to Fatou Jalo, who's not on this presentation, but she actually is the one who initiated all of this work. So thanks to her for her persistence and for having us continue with these updates. Thank you all, and I now pass it over to Audrey.
Wonderful. Thank you so much, Amani, Elena, Tabitha. I know we have several questions. Could we go back one slide? I know we have several questions in the Q&A for live discussion. Dr. Emily Sonneveldt of Avenir Health will be moderating those questions. Emily, can you get us started?
Sure, happy to. So I think maybe I'll start by answering two of the questions that were posted. One providing a little bit more information to a question that I actually responded to, and then maybe hand over to Marcus, who's also indicated that there's a few questions that he'd like to respond to. So right at the very beginning of the webinar, there was a question around whether or not the updated CYP factors were included in the FP 2030 annual estimates. So I did type a response, but just to provide a little bit more information, those factors have already been integrated into the tools that are used by countries to produce those annual estimates. And actually the timing of this is pretty good. So right now countries are actually producing those annual estimates. So it provides an additional opportunity for these new conversion factors to be discussed and disseminated in country as they integrate some of these new estimates into their discussions. So this timing works out within that. The next question that I'd like to respond to is why not use DHS data for continuation? So I can say that part of the process in doing the estimates did include looking at DHS discontinuation data, but there was a decision back in 2011, which I think aligns with the update also in 2000, to focus primarily on studies that were actually tracking women and their continuation as they were using the method instead of doing retrospective analysis. So those prospective studies were actually favored when we were looking at the data. However, that information was compared and the analysis looking at continuation rates from DHS was looked at as well as part of that decision-making process and was discussed as the final data sets to be used in the estimates were being decided. And then maybe I'll say to one more about the overlapping coverage before I hand over to Marcus Steiner. So it was mentioned in the presentation that overlapping coverage was dropped from the conversion factors in 2011. And just to provide a little bit more information, calculations of what the different factors would be, whether if overlapping coverage was included or not, was done for all relevant methods, and it did not change the conversion factor at all. So we actually went back and did the same test using the 2000 estimates as well in 2000, including the overlapping coverage did not change that factor either. So since there were 2 rounds where that factor was sort of irrelevant in the final estimates, we decided to remove it then. However, of course, if there's ever any concerns going forward, that same test can be done to decide whether or not it needs to come back on board. So maybe with that, I'll pause for a minute and see if Marcus, if you'd like to jump in and respond to any of the questions that you marked in the Q&A box.
Okay, yeah, there was one question about how that wastage may be different in the private sector versus public sector, and if we made a distinction. And I just want to point out these are very crude measures, and there's just not good data on how different the wastage is in the 2 sectors. So while that question is a good question, it's basically ignored because of the crudeness of the measure. And then the second question was about paracoital contraception. If EC is being used, how do you know if a person is using it for paracoital contraception or not? Basically, we came up with a paracoital CYP because the FDA in Ghana was asking for that question. And I think this indicator will be useful for lobbying for normative bodies as well as interacting with regulatory bodies. And until there's actually a branded paracoital contraceptive brand, it will not be used in programs. But hopefully there will be a branded paracoital contraceptive at some point in the near future. So those are the 2 questions I was especially interested in addressing. Thanks.
Okay, great. I can jump back in with responding to a question that was put in French about how will the changes happen at the country level. And I think that is up to the countries to access the materials that are being shared on this webinar and will be available to all participants, which not only provide the updated factors, but also have a brief that explains the process in which these factors were developed, so that information can be shared and all of our colleagues can help support that dissemination. And then the next one was, there was another question that was posted about whether or not CYP conversion factors should be updated retrospectively in countries so that they can do comparisons with back estimates. And I think that really depends on how the country is using it, but it is important to realize that some of these changes will make current year CYP factors hard to compare to previous year CYP factors. So it depends a little bit on how you want to approach that. You can look, each country might make their own decision, but it is important to understand that comparability will have a sort of break in that chain going forward if you're disseminating or your country is using any of the methods with a change in factor. And then a new question did just pop up about, is it possible to get tailored specific tables of CYP conversion factors to each country based on the methods available? So the overall global table is available on the USAID website, and I think we can share the link to that, so that's available. So those would be the factors that would be recommended to be used across all countries. So I'm assuming that's what you're asking. If the question is asking whether or not you think that countries should make their own CYP factors, I think we would probably agree that the answer to that is no, that we should stick to the internationally sort of validated ones that are posted on that USAID website. And maybe I'll take a pause for a second and see if there's anybody else or any other panelists who'd like to jump in and respond to any of the other questions that were posted.
I'll take, oh, actually, I think Emily was about to update that one. So someone was asking when we expected the next revision to occur. considering there's, self-care products are coming to the market and whatnot. So I think what we tried to do with this update is kind of develop a process to state when an update should be triggered, when the next update should be triggered if you follow the flow chart we presented. So our hope is that in the future, that whenever there's a change that is large enough to trigger an update, it will happen maybe not every 10 years. Thank you.
We do have a hand up as well. Vincent, I see that you've got your hand up. I'm going to go ahead and allow you to unmute to ask your question. Go ahead. Vincent, are you there? Oh, we've got the hand down. Well, you're welcome to answer your question either over your microphone or via the Q&A. We've got another hand up from James.
Yes, hello. Thank you so much for the presentation. I have typed a question there, but I've not seen a response. There are situations whereby at the health facility level, they do give to the clients more than one packet of family planning method. So in such an instance, should we be using the number of cycles or the number of the packets which have been issued, or should we be using the number of clients to whom it has been issued? Thank you.
I can respond to that question. So CYP factors are based on the products that are distributed to clients. So you would, in all cases, you would use the number of products or the number of packets distributed in your calculation.
Thank you, that's well noted.
Excuse me, I see a couple of questions about Depot Sub-Q or Cyana Press about what would trigger an update. So I think if you follow the kind of process we outlined, if there was a change by a regulatory body that said that the product was a 4-month product rather than a 3-month product, that is what we would use to trigger the update for Depot Sub-Q. Thank you.
I think there are 1 or 2 questions now in the chat around whether or not there will be guidance coming about doing retrospective calculations if you're in the middle of a project and you're reporting CYP factors as one of your key indicators, and whether or not there will be some sort of guidance distributed to those projects about doing those calculations and how to integrate the new CYP conversion factors. So I don't know if there's anybody who wants to respond to that question.
Emily, do you mind repeating the question? I think some of us may have missed it.
I don't. I'm sorry about that. So the question is whether or not there's going to be guidance coming for projects who are reporting on CYPs and how to start using the new conversion factors and not break sort of the comparison between previous years or any targets that were set in their contracts. Whether there'll be guidance coming out for projects on how to do that.
why don't I take that on, I'll let him, maybe Amani has a comment. I think that's a conversation to have with the project team as well. I don't think there's not going to be guidance across all projects for this application. I suggest that you have a conversation with the AOR/COR on that.
Okay, and then maybe I can respond to a question that just came up about the sort of clarifying the reason why an update to the factors may be triggered by Depot Sub Q, because there might be a change in wastage of the project when it's self-injected versus provider dependent. So I think that's a really good question, John. But I think it puts us in sort of that same bucket that Marcus talked about earlier, which is there's usually very little data available on wastage for any method. And so integrating wastage into the factors has always been sort of an area of large discussion about how to do it, how much weight to give it, where to get that information. So I think, you know, although it would be great if all of a sudden we did have some actual data available on wastage, I definitely see the logic in terms of how you're differentiating wastage levels based on who's doing what. And if we can get data on that, I think that's great. But I imagine that we'll end up in the same situation that we are now with the other methods, that we sort of think that's true or know that's true, but we don't have a lot of evidence to underpin it. But I would agree that if evidence does become available, that it is something that could potentially trigger an update for that method, or at least a discussion about an update to make sure that we're reflecting that sort of change in provision. Okay, and I think, Tabitha, do you have your hand up to answer the question posted by Binod?
I do. I think that was by accident, but I will answer it live. So yes, so any stakeholder that actually uses CYPs needs to know about this update, and that the final update lives on the USAID website. And so with the, we do ask for you to disseminate the brief, notify folks that there is an update to the CYP conversion factors, basically to anybody who utilizes it.
And we do have a couple more hands up in the participant list. I'm not sure who had their hand up first. So Jennifer, I'm going to go ahead and allow you to unmute if you want to ask your question.
Thank you. Good morning, afternoon, and evening to everyone. So I'm stuck a little bit on the different CYP factors for pericoital versus emergency contraception. And unless I'm mistaken, in the public sector, folks will just check emergency contraception as being dispensed. So there's no, in registers, there's no differentiation between the different usage. And it's the same for in the private sector, that these pills are sold, and they aren't sold with the understanding of pericoital versus emergency contraception. So how can we apply these different conversion factors if we don't really know the intention for how it's being used? Thank you.
So Emily, do you want me to take this question?
You go ahead and start, and I can jump in after if you want.
Yeah, I think it's going to be kind of a repeat of what I said earlier, that the CYP for pericoital is very useful to interact with normative bodies in terms of the lobbying process, as well as with regulatory agencies. It will not be used in programs until there's a branded pericoital product, which hopefully will happen at some point in the near future. Does that answer your question?
Yes, thank you, Marcus. I'm sorry, I missed that before. That makes sense.
Thanks.
And I can respond to a question that just posted around the calculation factor for sterilizations, since there isn't a commodity per se associated with that. Sterilization factors are calculated slightly differently. They're calculated based on the average age of sterilization. So it's looking at the amount of time on average a woman would be protected based on when within her reproductive years she is most likely to be sterilized. So it's done slightly differently since it isn't commodity dependent. There's a few other adjustments. It's not just age of sterilization, but that's the main input that differentiates locations.
We have a question in the Q&A about developing CYP for dual prevention pills or other MPTs. Would anybody like to speak to whether that is in the pipeline?
Sure, I can take that one. So we need to have an actual product SRA approved and available. That would be in the pipeline for us to include, but when we actually have a product.
We are coming up towards the end of our time, and I know many of you are heading offline for the evening or getting started with your work for the morning. So I do think we need to begin to wrap up. We have many questions in the chat, including many questions in French. And I do want to make sure that all of you get responses to that. We'll plan to regroup as a team and get those answered and include those in the post-meeting materials that are distributed to all attendees. Thank you so much for your thoughtful questions and comments. Can we head to the next slide, please? So as a reminder, you'll receive a link to the recording and slides this week. You'll also receive a link to access the full list of unanswered questions so that your question can be answered by our presenters. We've linked to many CYP resources in the chat. Please disseminate those materials to partners and colleagues broadly. And if you have additional questions, please contact the individuals listed on this slide. Their emails will be included in the post-meeting materials you'll receive. So thank you again so much for joining us. We really appreciate your thoughts and feedback on this important process. And I hope that you all have a wonderful rest of your day.